Good day, friends, and a warm welcome to our fifth episode, the fifth episode of 4D Season 3.0. And 4D stands for Detailed Discussion and Dialogue in Diabetes. This is the fifth episode, so we have a question for you. Now, in India, we are used to our currencies being arranged in decimals. So, for example, 1 rupee has got 100 paisa. But there are two currencies which are based on the unit 5. And a quiz question for everyone. Let's talk about the power of 5. Which are those two countries where the currency is not divided in decimals, it's divided in units of 5? That's a quiz question. We have a hint as well for you. Both the countries have names that begin with M. And both of them are from the great continent of Africa. Now, with that question, let's talk today about 5 pillars. We'll talk about 5 pillars that we use in cardiac, renal, and glucose control. To do this, let's get 3 stalwarts then to discuss this with us. So a warm welcome to our stalwarts for episode 5, season 3.0, 4D. And I'd like to welcome our first stalwart, Dr. Akash. A warm welcome to Dr. Akash. He'll be joining us shortly. We also have 2 more stalwarts with us. So a warm welcome to Dr. Jaimin Somani. Dr. Jaimin is a consultant nephrologist at the Sterling Ramakrishna Hospital in Gandhidham in Kutch in Gujarat. Warm welcome, sir.
Hello, sir. Thank you, sir.
Joining him is Dr. Ashu Goyal, who is a consultant endocrinologist and diabetologist at Kiran Hospital. He specializes in endocrinology and diabetes both, and he has a patient-centered focus. Warm welcome, Dr. Ashu.
Thank you, sir. Good evening, sir.
And Dr. Akash will join us shortly. He is also from Kutch, from Gandhidham. We are talking about the power of 5 today. Let's talk about 5 drugs that have now emerged as pillars, not only in glucose control, but also in cardiac and renal care. We'll go through them one by one. The SGLT2 inhibitors, the GLP-1 receptor analogs, insulin, metformin, sulfonylureas. So let's begin with Dr. Ashu. Dr. Ashu, these are all pillars. They are glucose-lowering drugs. But are these drugs that are meant for just glucose control or things beyond that?
Sir, now the diabetes management is not just limited to the glucose control, but it is beyond that. And it's today's scenario. It constitutes the cardiorenal benefit along with the glycemia management. So these pillars are basically stemmed for the cardiorenal benefit along with the glycemia.
And we welcome Dr. Akash as well. Dr. Akash Ramchandani is a cardiologist. Yeah, welcome. So as he joins, the question is, we were talking about pillars of diabetes care. The SGLT2 inhibitors, the GLP-1RAs, insulin, sulfonylurea, metformin. Are these cardiac drugs, Dr. Akash, or are they just glucocentric drugs? The question is, when you prescribe an SGLT2 inhibitor or a GLP-1RA, do you think that you are prescribing an endocrine drug or a cardiotropic drug?
It's a card, sir. Basically, sir, the drugs, as we know that the SGLT2 inhibitor has come as a glucocentric drugs. They are the diabetes control, but they turned into heart failure application. As we know, all 5 pillars of beta blocker is ARB and spironolactone, the MRA, the mineralocorticoid antagonist. Now the SGLT2 also has become the part of that pillars. So I don't see as even patient who's non-diabetic also we prescribe the SGLT2 inhibitor very regular. Even in the case of we see that cardiorenal syndrome. So in case of cardiorenal syndrome, also in cardiorenal syndrome, it is difficult to initiate ARB in these cases. So in these cases, the SGLT2 is the perfect drug for the cardiorenal, the heart failure.
Thanks. Dr. Jaimin, Dr. Akash spoke about the cardiorenal syndrome, which means the heart and the kidney, they go together. The beauty is when you read the Bible, so you know that renal, it comes from rein, R-E-I-N, which is an old term. The beauty is that when you read the Bible, wherever they talk about the heart, they talk about the kidneys as well. So earlier, the kidneys were thought to be the seat of the human soul. In fact, in some civilizations, like the Egyptian civilization, it was thought that one kidney tells you all the evil things, The other kidney tells you all the right things, the correct things, and then you have to balance between them. Perhaps the reason for that was it is very difficult in an animal to dissect and to reach the kidney. The kidney is situated in a situation where you have to work very hard. So since it is a deep-seated organ, people thought that all the deep emotions are hidden there. But I have a question, Dr. Jamin. When we all use in English the word cardiorenal, and the Bible also uses first heart and then reins, do you think that's right, or should it be renocardiac?
It's the vice versa, sir. Cardiorenal actually have different types, type 1, 2, 3 and 4. And it includes both cardiorenal and renocardiac as well. So type 1 and 2, basically cardiorenal acute heart failure or acute MI can lead to decrease in blood pressure and renal involvement. And in case of AKI or CKD, when it affects the heart, it becomes renocardiac. So it's interconnected and vice versa, sir.
If we get Dr. Ashu in the discussion, Dr. Ashu, now we have these pillars that we'll talk about today. And when we see the pillars of glucose control, the pillars of heart failure management or cardiotropic management, and the pillars of chronic kidney disease management, they all appear virtually the same. If at all there is a difference, for example, the kidney pillars contain MRA, mineralocorticoid antagonists. The heart failure ones don't contain right now, but they will, because with newer studies now we know that finerenone is equally effective in heart failure. But let's go through them one by one. Dr. Ashu, these are 5 drugs that we have. Any one of them, would you like to share the mechanism of action? So let's just go to threes. To these 5 drugs one by one. SGLT2 inhibitors, GLP-1RA, insulin, metformin. Yeah. Any one, yes.
The GLP-1, they because of natriuresis, they decrease the intra pressure, also decrease blood pressure, increase the lipid profile, and decrease the oxidative. So these are the basic mechanisms with the SGLT2 inhibitor to control. They also improve the management of failure. CVD. So these are the SGLT2.
So this is nice. When you see the answer, you find that it includes the heart, the kidney, and that answers Dr. Jamin's point also. We began by talking about the kidney. So even though the word cardiorenal is used or diabetes is used, when you begin explaining SGLT2 inhibitors, you start with the kidney. So that gets prime importance. But Dr. Akash, let's continue with this. There is something known as the Robin Hood hypothesis. So what the Robin Hood hypothesis says is that SGLT2 inhibitors, they steal from the rich and give to the poor. They steal from carbohydrate-based metabolism and give to fatty acid-based or ketone-based metabolism. And then they are able to balance the requirements of the cardiomyocytes. So the cardiomyocytes are kept happy. They have neither too much of carbohydrate nor too little. And they have just the right amount of ketone-based metabolism. Is there any other aspect in the heart or in the vasculature that you feel we should highlight when we prescribe SGLT2 inhibitors?
Sir, like as you said, that metabolism is the ketone bodies was dependent on the ketone, and similarly the SGLT2 inhibitor also reduce the volume slightly volume also, like it does the glycosuria and the natriuresis also. So that also help us to just settle down that decrease some amount of volume, plus it reduce the metabolism of carbohydrate also. So similarly, as you told that and it has the help in the similar state, like it do the osmotic diuresis. So it has that mechanism, second mechanism also, like osmotic diuresis. So by that mechanism, it reduce the volume overload kind of. It's not that much, so percent is comparatively very less, but the glycosuria and the osmotic diuresis is also one of the phenomena in case of osteoporosis.
When I was a student, our classification of anti-hypertensive drugs used to be as follows. Those drugs that reduce the afterload, those that reduce the preload. And SGLT2 inhibitors are actually able to reduce both. In fact, all 3, they reduce the preload, they reduce the afterload, and they also improve the strength of the pump, that is the myocardium. Dr. Jamin, we initially used SGLT2 inhibitors for their glucose lowering benefit. And we were afraid of using them when you look at the earlier guidelines from 10 years ago. We were afraid of using them if the EGFR went below 45. What does KDIGO say now? And then we use the drug maybe in dapagliflozin in a person with an eGFR of 20, 25. Are we using it for glucose lowering, or are we using it for vascular benefit, for renal protection?
Sir, at that GFR, definitely SGLT2 have renal protective, decreasing albuminuria effect, and it delays the progression of CKD. So, uh, as far as glucose control is concerned, definitely it helps to lower the glucose, but there is significant added advantage for renal protection. And if we talk about the guideline, then KDIGO allows the use of SGLT2 inhibitor up to GFR 20-25, because beyond that low GFR means at the GFR 10 to 15, there will be no secretion of drug in the renal tubules. So technically, they are not going to help much. That's why the 20 GFR is a fair enough cutoff. And yes, definitely above this GFR, it significantly lowers the intraglomerular pressure. So it by tubular feedback mechanism, it causes dilatation, constriction of the afferent arteriole, and hence why decreases the intraglomerular pressure. Intraglomerular pressure has been decreased, so that albuminuria is decreased, and decreased albuminuria lead to renal protection, cardio protection, and all that benefit.
So, Dr. Ashu, if you remember at the beginning of the question, beginning of the event today, we asked a question: which are those two countries where the unit of the currency is divided into 5 parts, not into 10 parts or 100 parts? And we have an answer coming in from Kota in Rajasthan. So Dr. Parth Jethwani and Dr. Khyati from Kolhapur in Maharashtra both say that these countries are Mauritania and Madagascar. Mauritania and Malagasy Republic. In both these countries, the currency is divided into 5 parts. So, Dr. Ashu, with this, we are talking of 5 pillars. Let's conclude the first part. Dapagliflozin now seems to be a cardiac drug, a renal drug, a glucose lowering drug. All these are confident indications for treatment, clear-cut indications. But are there any contraindications, any caveats, any concerns? Do you see any misuse of these drugs in practice, and how can we prevent it?
Sir, the one contraindication for dapagliflozin is if the patient is having the urinary bladder cancer, then it is a one contraindication. If the patient is not taking orally, then we do prescribe the SGLT2 inhibitor because of this. Maintain on the hydration status is necessary for the SGLT2 inhibitor. And another is it can cause also the euglycemic ketoacidosis with the SGLT2 inhibitor. So these are indications, and if a UTI or we have to maintain.
So we must be aware of these in this checklist. When you initiate dapagliflozin, do ask these questions, and when the patient comes to you for follow-up, again ask them. Dr. Akash, from a cardiac perspective, any contraindications, any concerns? Should we worry about blood pressure or maybe ejection fraction in such patients? Those who are on dapagliflozin.
Correct, sir. Sir, only thing we have to watch is the hypotension. If it's hypovolemic, so then we have to just cautious with the SGLT2 inhibitor. Second is the UTI. So UTI, we have to take care of genitalia, and the proper volume status of body is important. As we know that as I told, sir, in heart failure patient, the heart failure with reduced EF and heart failure with preserved EF. We know previously with heart failure with preserved EF, only medication was the spironolactone, which was effective in case of heart preserved EF. All other drugs we give didn't reduce the mortality. But now, as we know, the Emperor Reserve trial and the Deliver trial for the DAPA and the Emperor Reserve trial for the empagliflozin, both has shown that there is a significant reduction in mortality of these drugs. So these drug has become very important in case of heart failure with reduced EF and heart failure with preserved EF. So only the contraindication we have to see is the urinary tract infection, which can turn into the florid infection, and second is the hypotension. So we have to manage the volume very well, because in the case of heart failure, we see that we are titrating the dose of the diuretics also. Sometimes we find there is a hypotension, then he can correct the volume status and become the BP has become big. He can become normal also. So managing the volume status and looking for UTI are the two important aspects in the case of the SGLT2i.
Thanks. Dr. Jamin, would you like to add a nephro perspective? In general, people with CKD, they are more complicated than people without CKD. So you get the toughest of all our patients. Any insights, maybe from an electrolyte balance perspective or from a renal function perspective?
Sir, first, the GFR should be more than 20 to begin with. If GFR is below, then we should not use SGLT2 inhibitor. And Anshu sir has rightly said the presence of UTI, history of recurrent UTI or bladder cancer or hypovolemia. These are a few contraindications. And apart from that, if a patient is on ARB or ACE inhibitor, then adding SGLT2 inhibitor can lead to decrease in GFR in initial 7 to 10 days. So yes, so we have to use cautiously this drug with ACE inhibitor and ARB, because one drug will constrict the afferent vessel and one drug will dilate the efferent vessel. So there can be if we start both simultaneously, then can be a AKI or a significant drop in GFR. So after starting this medicine, at least recheck the creatinine and potassium after 7 to 10 days, so that up to 20 to 30% decline in GFR in initial days is okay. But beyond that, then we have, if it is more than that, then we have to see for volume status or any other drug interaction. So yes, the GFR, potassium level, volume status, ongoing other medicine should be taken into consideration.
So these 5 pillars that we are speaking about today, they remind me of the Pandavas. And all the Pandavas had a different fighting style. All were excellent. They worked best as a team. That is what we must remember. All these drugs that we are speaking about work as a team. And all of us as physicians, whatever specialty we practice, whatever expertise we have, if we work as a team with each other, we get the best possible. Then we will win the Mahabharata against diabetes and against heart disease and kidney disease. But the SGLT2 inhibitors then remind me of Bhim amongst all in the Pandavas. Bhim was very good at fighting, but he could cause a lot of collateral damage. So you have to be aware of that. If we move on to the next pillar, Dr. Ashu, GLP-1 receptor agonist, how do these work? And do you think that with today's knowledge, we can call GLP-1RA the Arjun of all these 5 Pandavas?
Yes, sir, surely. So, receptor agonist is another molecule which is important in the diabetic management as well as basic, along with the vector. So, it is like as you said, in the management of the diabetes, along with the cardiorenal. So, GLP-1 is a small, it is molecule hormone which is very release of the gastrointestinal mucosa. It is having a incretin, induces the post insulin release. It suppresses the glucagon release and increases the satiety, important in the management of the diabetes along with the overweight or obesity.
So GLP-1 receptor agonists, we have in our country now liraglutide, semaglutide, yes, and we also have tirzepatide, which is a dual agonist. We can consider that these are the Arjun out of all the Pandavas in the when you talk of the pillars of metabolic care, and they act on various ways. So Dr. Akash, Dr. Jamin, when you listen to Punjabi music, we are all very fond of Gujarat. Half of our songs are built around Gujarat. One of the most popular Punjabi songs is Dil Legi Kudi Gujarat Di. So my heart has been taken by a Gujarati lady. We have another song which says that our culture has 4 B's. Bhangra, Bistar, Beer, Bater. So that means dance. Bistar means the bed. We are very lazy. We love sleeping. We love dancing. We love sleeping. Bhangra, Bistar, beer. We love alcohol. And Bater is partridge, which means wild meat. So basically good food. These 4 B's you use also to understand the role of the GLP-1 receptor agonist. So if you find it difficult to explain to a patient in the medicine OPD, why would you like to take? The patient says, how does this work? So you say there are 4 B's: the brain, the bowel, the pitta cell, and the brawn or the bulk. All these 4 B's talk to each other. They talk to each other through hormones. The hormones can be houseful hormones or hungry hormones. So some hormones mediate satiety, others mediate hunger. They can be happy and healthy hormones, or they can be harmful hormones. An example of a harmful hormone would be some of the adipokines that we have, the oxidative stress, the free radicals. As long as these are talking to each other properly and listening to each other, the body remains in sync, in balance, B for balance. But the moment they stop listening to each other, then they get involved in a vicious cycle of obesity. And this obesity is not limited just to adipose tissue anatomy or adipose tissue function. It impacts each and every aspect of the human body, each and every organ system, right from the brain, benign intracranial hypertension, up till the foot, maybe atherosclerosis, lymphedema, all these are associated with obesity. Once you have done this, then Dr. Akash, then the patient will ask, sir, is there an entity like the obese heart? Can you have an obese myocardium? Can you have epicardial fat, pericardial fat? And you do echos every day. Are there changes that you have seen in your practice that the average echo, so like we have got Indian reference man, Indian reference woman in our country from a weight perspective. Do you think that the reference echo is changing for the average Indian adult? Dr. Jamin, the obese kidney, is there something like obesity associated glomerulopathy? Can obesity cause? Yes.
Definitely, sir. We call it secondary FSGS. So primary one is because of the kidney and kidney involvement per se, but the secondary FSGS is because of obesity. So yes, definitely obesity lead to proteinuria and focal segmental glomerulosclerosis, and it can lead to CKD and even ESRD if not managed properly at time. So yes, obesity, and in other CKD apart from FSGS, in other CKD also obesity will aggravate the ongoing kidney damage. So definitely obesity is a concern for kidney as well.
Thank you. Dr. Ashu, when we counsel our patient about taking GLP-1RA, what do we tell them? Do we tell them that this is just a weight loss drug? It's just a glucose lowering drug, or do we talk about other organ systems as well? What are the advantages of GLP-1RA use in metabolic health?
And the cardio benefit are along with the diabetes management, overweight, obesity. These are the another benefit with the GLP-1 receptor agonist. We have to counsel the patient about the side effect of the GLP-1 receptor agonist with the nausea, the gastrointestinal upset. These are the big main side effect with the GLP-1 receptor agonist.
So then that means that when you have to counsel patients, it means that GLP-1RA also, if used without counseling, might end up working like Bhim. That's true for dapagliflozin as well. But if you use these drugs with the proper counseling, then they will work like Arjun. So I'm reminded of Dronacharya's story where he asked all his students, all the 5 Pandavas, to focus on the eye of the bird. So he asked Yudhishthira said, I cannot see the bird. Somebody said, I can see the entire tree, the entire forest. And somebody said, sir, I can't even see the bird. I can see only the eye of the bird. That was Arjun. So we need to be focused and we need to be aware of what we are doing. In some situations, Dr. Ashu, maybe we are not very comfortable giving GLP-1RA. Perhaps the patient already has GI dysfunction, is already complaining of gastroparesis, or has not tolerated the drug in the past. In such situations, can we use DPP-4 inhibitors like sitagliptin?
Sir, if the patient is having the pancreatitis, then both the GLP-1 as well as the DPP-4 both are contraindicated. But if the nausea is simple there and patient is not tolerating the GLP-1, then we can add the DPP-4 inhibitor for the patients.
And what are the other advantages of sitagliptin? So you work in a center where you have urban patients, rural patients. Some of your patients come to you from far off districts as well. They are not able to come regularly. What are the advantages of sitagliptin when you write it? This is from a physician perspective.
Sir, sitagliptin is basically it has not shown any cardiorenal benefit with the placebo, sir, in comparison to the placebo. So sitagliptin is basically mainly with the glucose management.
So that's for glucose control, and it's neutral from a CV outcome perspective. Dr. Jamin, from a nephro perspective, can we use sitagliptin? Should we be aware of a dose adjustment and any challenges that you foresee when we use this drug?
Sitagliptin we can use in CKD. but dose should be 50 mg is fair enough. But linagliptin, we can use linagliptin in CKD without any dose adjustment. So vildagliptin and sitagliptin will require dose adjustment, but linagliptin is safe with CKD. So even in stage 5 CKD, we can use linagliptin without any dose adjustment. So yes, I would prefer linagliptin if the CKD is there. Yes.
So we've talked about the two pillars so far, SGLT2 inhibitor and GLP-1RA. And we see that Dr. Akash is out in the very beautiful Akash. So Dr. Akash, it's an all India meeting that's going on. The first question coming from Coimbatore in Tamil Nadu is, what does the word Akash mean? And the second question is that an entity known as obese heart? When you manage diabetes and metabolic disease also, when all of us do that in the OPD, remember that it is as vast as the entire sky. The spectrum of metabolic disease is so vast. Each and every person will come with their own permutations, combinations. Some people will come in simultaneously with cardio, renal and metabolic dysfunction. Others may come in sequentially. The sequence may vary. Somebody got diabetes diagnosed first, another person maybe got albuminuria first, and then after some time got diabetes. It might be iatrogenic also in some places. Let us say FSGS treated with corticosteroids, and later on you end up with dysglycemia. But irrespective of what the order of presentation is, we as physicians should be astute enough and we should be observant enough to look not only for one disease. The patient has come maybe with albuminuria, with a report of urine protein 4+, or has come in with diabetes. We should be able to look at each and every aspect of metabolism. We should be able to screen for cardiac, renal, metabolic disease. And apart from that, Dr. Ashu, what else do we screen for? If we can start from head to toe, maybe let's begin with benign intracranial hypertension and obstructive sleep apnea. And let's go up till the diaphragm, and then we request Dr. Jamin to take over for all the subdiaphragmatic complications. What are the other diseases that are common, that are commonly missed in the physician clinic? And if we can just enumerate them, remind ourselves, then we'll make sure we do a better job for our patients.
So dental hygiene is also need to be checked.
Yes.
Along with the foot toe infections are there. Any buccal is there. In particular, UTI is there.
So benign intracranial hypertension, obstructive sleep apnea, dental hygiene or periodontitis, and heart seems to be missing in action. But Dr. Jamin, what about the subdiaphragmatic organ systems apart from the kidney?
At the presentation, when there is a diagnosis of diabetes, so kidney should be checked at the first visit itself. We should monitor. We should first examine patient's creatinine level and urine routine and sonography. These three basics things should be done in the first visit. At least in the, we should address patient that this kidney check should also be done, because sometimes CKD may be the presenting complaint as well in diabetes. So presence of proteinuria we should look for, and other part retinopathy, we should also check for retinopathy and neuropathy.
And Dr. Ashu, Dr. Akash, Dr. Jamin, what about liver disease, fatty liver? How frequently do we see this in our clinics? Dr. Akash is with us. Dr. Akash, how frequently do you encounter a high SGOTPT or an ultrasound report saying fatty liver, fatty infiltration? How frequently do you see fatty liver in your clinic? But Dr. Ashu, your comments on this question, and then Dr. Jamin.
Now I am
Dr. Ashu, please.
Sir, most of the patients, those who are the ultrasound report shows that the patient is having the fatty liver disease or mild fatty liver. Most of the urban patients shows the obesity with the diabetes, and the ultrasound report shows the fatty liver.
And I myself am guilty initially in my earlier years. So first, we never used to see fatty liver actually 25 years ago in our patients. Now we've begun seeing fatty liver, fatty kidney, fatty pancreas, fatty virtually everything. And I'm sure Dr. Akash sees a lot of fatty pericardium and epicardium as well when he does the echo. So I used to be guilty of saying, "Arey, ye to kuch bhi nahi hota. Don't bother. Everybody gets a report like this, so don't bother." But that is trivializing disease, because now we know that this hepatic dysfunction is not just hepatic; it is multisystemic. So now my counseling has changed, and now it is, yes, the ultrasound doctor has done a great job. See, we asked her for the prostate and kidney, but she has actually gone out of her way to give you the texture of the liver and also to give you the size of a liver. So you must say thank you to her. She has opened our eyes. That is all that it takes, 20 seconds. Now suddenly the respect for other medical colleagues has gone up. Respect for you will also go up in the community. Second, the patient understands that now the liver is important. And then you say that, yes, I am going to give you such and such treatment, which will help not only your heart and kidney and glucose, it will also help your liver. So you're adding one step, one extra advantage to whatever you have prescribed, which can be dapagliflozin, which can be GLP-1. Even when the SGOT-PT is high, then also we say that, yes, this is very important. We must check it again after 1.5 or 3 months. And these are the lifestyle measures you should follow. These are the drugs that we can prescribe. There will be situations where you will focus and you will prescribe resmetirom, which is available in the country now at fairly economical rates. So, but the first step is to counsel the patient correctly when the patient has come to you. Apart from these, there are other aspects also of metabolic medicine that we miss many times. Polycystic ovary syndrome. Especially male healthcare professionals, we will forget to talk about contraception and conception. So we must talk about that as well to women of reproductive age, also to men of reproductive age. We should talk about the concept of epigenetics and why men of reproductive age who are planning a family, they should keep their glucose and blood pressure under check. Lymphedema, edema, one term that we use is obestasis. So Dr. Jamin, obestasis means the edematous kind of a feeling, or the edema, multifactorial edema that you get in people who are obese, and it's caused by so many factors. How common is edema in the nephrology clinic, and any caveats for us as physicians? Any mistakes we make when we are treating edema? Any simple things that we can do to improve our practice?
Sir, my examination generally begins with feet to look for edema. Yes, so yes, edema is a concern. Sometimes it may be because of obesity, as you correctly said. Because of obesity, there is hampered in venous return. It can lead so that they can have varicose vein or venous edema. Other thing, they can have proteinuria or CKD that can have lead to pitting type of edema. It can be cardiovascular low ejection fraction or right heart failure that has given rise to edema, or concomitant thyroid disease, volume overload. So yes, edema or some medicine side effect like amlodipine or pioglitazone. So yes, edema must be checked in every patient, and the cause of it should be found out, and it should be taken.
Thank you so much. Dr. Akash, in cardiology OPD also we see a lot of edema. So what are the common causes? Any mistakes that we make in our practice? Anything that you have seen, and how can we improve our care?
Yes, sir. First of all, sir, sometimes the complaint they are on antihypertensive and they have sped. So amlodipine, the calcium channel blocker, is one of the common cause that is the pedal edema of the pedal edema. Other than that, there are the causes like anemia, hypoalbuminemia, or reason like cirrhosis of liver can present with the pedal also. Specifically in cardiology OPD, what we find, sir, the male patient around 56 of age, he is obese with the complaint of exertion and has pedal edema. These are the sometimes classical place of the heart failure with reserve ear. So many patients of heart failure with reserve ears, we diagnose it only with the pedal edema also. And so that's how we should take care of like all these other like CKD and the liver cirrhosis, the early liver cirrhosis, and all these reasons. We know that pedal edema has one of the most ignored and the most like we do the echo also. Sometimes someone tells who is normal, but there is a significant vascular dysfunction also in these patients. So these are the cases. Pedal edema should not be ignored in the case of heart failure with preserved ear. In echo, how we can find it? He finds a dilated LA, and concentric LBH. So these are the features like the heart failure with preserved EF. The characteristic there is the LA cardiomyopath. So and sometimes we find the respiratory like LA and RA both are slightly balanced. So heart failure with preserved EF, specifically in older individual, specifically in female, is the cause of fatality. They first present with the fatality.
Thank you. And there was another question from Dr. Pavan Vadhavan in Panipat. He says, sir, is there something known as the obese heart? And how do we pick it up on echo and on other investigations as well as clinically?
Sir, the obese heart, we can tell it is the similarly the heart failure with preserved EF. As I told that we find that echo will be the normal side. But if we find suspicion of the added dilatations, and when we see the cancer, like patient at risk of there are multiple coronary like risk because long standing diabetes is the early phase of the heart failure, sir. So they present with the heart failure and with the underlying coronary risk factor like the atherosclerotic risk factor, diabetes, hypertension, and age also. So they present with the cardiac risk factor with the changes of the hypertensive cardiomyopathy, the changes of the LA cardiomyopathy. The classical.
Is this true, sir, that with obesity, even diseases like atrial fibrillation increase?
Yes, sir. Sir, obesity as a state of the volume overload state. Patient is running on the like normal 5 per minute. So that state has become 6 to 7 liter because body surface area is increased. So heart has to function higher. So in these cases, sir, as I told that, and with that the upper load is significantly increased over the volume which we have to provide the LV is comparatively higher. And with that, over the time, the restrictive filling has reduced. So, with the diastolic filling has reduced, that lead to the LA cardiomyopathy. It's a similar concept as the heart failure with preserved EF. These patients are more of tend to have the atrial fibrillation. The second reason which we know, sir, is these obese patients are more prone to having the obstructive sleep apnea and the hypoxia during the night. So, this is the one of the reason like multiple episodes hypoxia in the night with the obstructive sleep apnea. That trigger atrial cardiomyopathy, the atrial and atrial fibrillation also. This is one of the second most common reason of the atrial fibrillation. So, volume overload state, the LA cardiomyopathy with frequent events of hypoxia that lead to the atrial fibrillation. Because
And now
yes, sir.
Carry on.
So, in this, we know that in obstructive sleep apnea, sir, in this case, this is the highly sympathetic activity over the night, sir. Patient is suffering from a fluctuation of activity over the night. So they are sometimes the over sympathetic activity, then sometimes the vagal dominant activity. So these activity lead to the more generation of the atrial.
And we should be aware of all these things. So the interaction between the heart and kidney, we always speak about that, the liver and kidney, but we should also be aware of the interaction between endocrine, neuroendocrine, and the autonomic nervous system, all these factors as well. Dr. Ashu, we were talking about the 5 Pandavas, and we talked about how both dapagliflozin and GLP-1RA can be viewed as either Bhim or as Arjun, depending upon the hand-holding that we are doing, depending upon the counseling that we are doing. But 2 of the cutest and the friendliest Pandavas are Nakul and Sahdev. And what about Metformin and sulfonylurea in your OPD? They've been around for so long. Do you treat them like Nakul and Sahdev, or do you treat them like the Kauravs?
Metformin is remains the drug of choice in the management of the diabetes if the patient is not having any cardiorenal risk factor. So metformin is unless contraindicated, it is a drug of choice. It should not be initiated in the EGFR is less than 30 if the patient is having the symptomatic heart failure or the liver disease because of precipitating the lactic acidosis. So the metformin remains the drug of choice in the management of the diabetes unless contraindicated or if the patient is not having any risk factor for the hair.
Thanks. And Dr. Jamin, in your practice, do you continue to use metformin and sulfonylurea? When you read accounts of lactic acidosis Do you feel that this is all theoretical? I mean, have you seen a patient of drug-induced, metformin-induced lactic acidosis?
Not so common, sir. Not so common. Yes. I do continue metformin definitely, as the Goel sir has rightly said that it's a fundamental drug, and when GFR is less than 30, we should not initiate it. But if it is ongoing, and we can continue it with GFR 15-20 also. So unless there is any other contraindication. And apart for sulfonylurea, there is a decrease in clearance of these drugs, so we should be cautious about the risk of hypoglycemia while continuing sulfonylurea. So yes, I do prescribe, but with a cautious approach.
We are speaking of the 5 pillars. We have spoken of SGLT2 inhibitors like dapagliflozin, GLP-1RA like liraglutide, semaglutide, and also the dual agonist tirzepatide. And as an option, you can always have sitagliptin in case the patient is not able to afford the GLP-1RA or is not able to tolerate that. We spoke of teamwork. Nakul and Satyev were twins, and usually we prescribe metformin sulfonylurea as a fixed dose combination, so they also come in as twins. And if you use them in the right manner, then they are very friendly. Of course, Nakul and Satyev were naughty also at times. When you read the history, Nakul by definition is a naughty person. And you see the smiles from some of our experts. You know now who is the naughty Nakul, who was the naughty Nakul when they were in hostel in MBBS days. But still, if you use them properly, they help. There is one contraindication or one caveat, which is we speak of teamwork, that all the 5 pointers work together. But when you use insulin and sulfonylurea together, it depends upon which insulin and which sulfonylurea. It would be a very bad idea to give a premixed insulin twice a day and a sulfonylurea twice a day. You can get away with antipodal prescription, which means at one meal I am giving a premixed insulin, at the other meal I am giving a sulfonylurea. I use this temporarily for some patients when I am stepping up. I want my patient to go to 2 or 4 injections. I did all the bargaining, all the motivation I could. Patient didn't agree, but she finally agreed for 1 injection. Okay, so at least take 1 premix with 1 meal. The other meal will give you an SU metformin. Or patient has been doing well on insulin. Now she says, can we de-escalate? So I say, yes, we can actually. Your kidney is fine. Your heart is fine. You did have acute kidney injury in the past. You did have tuberculosis or diabetic foot in the past. But now we've taken care of that. So let's try to de-escalate. So that is this antipodal prescription. So be aware of which insulin, which sulfonylurea. And then that brings us to the 5th pillar. That would be Yudhishthir, perhaps, if my memory serves me right. So Dr. Ashu, insulin. How important is insulin for you as an endocrinologist? And Dr. Akash, from a cardiac perspective, let's look at cardiology OPD and the ICU separately. So acute care separately and chronic care separately. So in the acute care setting, somebody comes in with uncontrolled glucose. What would you do for diabetes care?
Sir, in OPD care, first of all, definitely we will go with the SGLT2 inhibitor and the GLP-1 analog first. And with that uncontrolled diabetes, then this the optimal dose of the metformin and the sulfonylureas we have to give. If not controlled with that, then we should switch to the insulin. Insulin is always the last option as well. So in acute care, like patient presented with the acute atrial MI or heart failure, acute decompensation heart failure, in these cases, I will start always with insulin. And with GLP, with that, we will start the DAPA SGLT2 inhibitor also. So, and later, once patient recover from that, then we introduce the sulfonylureas and the metformin also. So, and with that care, sir, as we know that previously 7-8 years back when we go, the care with the insulin, the smoothness of the that like we had the premix and the regular insulin. Now the things has been slightly changed. It's a smoother management is comparatively smoother, and the monitoring has been very advanced. As we know, the glucose monitoring has come into picture. So now with insulin, with the proper management, the proper continuous glucose monitoring, and the doses of insulin, it has become comparatively more smooth. As we know, sir, the very good tennis player, the Alexander Zverev, he's a professional player. He's a top 4 or 5 tennis player. He is having type of diabetes, and he's managing the sugars on his court. So we can manage these patients at in OPD care basis also. the good endocrinologist friends, they are taking care of very well because they constant monitoring with the constant injection of the pump they have. So these are new. The technology has come very far, and insulin management has become very good in these settings.
And that point is well taken. We have better quality insulins now, and we also have better quality monitoring devices, which make it much easier for us to give safe and stable control to our patients. Dr. Jamin, from a renal perspective, chronic kidney disease separately, acute kidney injury separately, what is the role of insulin, and how do you manage your patients who are on hemodialysis? Their sugar seem to be going up and down all the time. Are they ever in the Goldilocks range? Are they ever in the right range?
Yes, sir. Sir, since you are talking about Mahabharat, I would say insulin is a Brahmastra. When nothing works, insulin will work. So, because if we talk about acute kidney injury, so we have very limitation in the drugs, and the GFR is also constantly changing. So we cannot use any fixed drug in acute kidney injury. So it's always better to use short-acting insulin. So I prefer short-acting insulin in acute kidney injury setting. And in CKD, when GFR is below 20 to 25, then there is limitation for OHA. So if fasting is much concerned, then I start with basal insulin and some OHA. So it also decreases the insulin injection burden, and the glucose control is also fair enough. And for dialysis patient, basal bolus therapy, or sometimes a single bolus will also sufficient for them. Or if fasting is not much a concern, then only bolus therapy. Depending on the body structure, the food habit, and the timing of dialysis, I think insulin is a wonder drug for dialysis patient. They can skip the dose pre-meal or pre-dialysis dose. They can skip and continue with the other two bolus doses. And this is how I manage the diabetes in dialysis patients.
That's also great insight. You can combine the various drugs together. So like we were speaking of our pillars of metabolic care, let's look at the importance of teamwork. Like all our experts have said, you don't have to view them as glycemic pillars or renal or cardiac pillars. They are all metabolic pillars. These drugs do not belong to one specialty. They belong to the patient. They belong to the person whom we are treating. And all of us have the right and the responsibility to use them in a rational manner. If we view this from the prism of the Pandavas, then we understand what teamwork is. We also understand the role of Dronacharya, the role of teaching, the role of hand-holding, and that's what we should do. We should work as humble. Remember the word humble and humane Dronacharyas for our patients, people who come to us seeking control. And if we can deploy our weapons or our archers or our fighters in the right manner, like Dr. Jamin said, sometimes you will use basal bolus, other times only bolus. That is also possible in renal disease. Other times only basal or premixed. Sometimes sulfonylurea with insulin, other times one drug alone. So if you deploy your archers and fighters in the right manner, then you will be able to get the desired outcomes. Our topic for today was the 5 pillars. We talked about SGLT2 inhibitors, GLP-1RA, then Metformin and sulfonylurea PC together, and the last one was insulin. Before we conclude, let's ask our experts if they have any take-home comments for us. So, Dr. Akash, the question for you is, anything new that you learned today, sir? And how does this insight impact your practice from tomorrow onwards?
Sir, one thing you told that they are the 5, the Mahabharat that analytics they have given. So, as you told, sir, most important thing, these are the metabolic disease. This is not the individual disease, as you told. We cannot see separately like it's cardiac disease, So basically, it's the spectrum of atherosclerosis, spectrum of metabolic syndrome, which we are treating. It is not like that we are treating the particular systems. So that is the most important thing which we have seen. And with that, how to manage with all these drugs, how to use these drugs judiciously, that is the more important.
Dr. Jamin, your comments. The same question asked to Dr. Akash, and also, do you feel that kidney health is getting its due importance in the country? This question comes to you from Dr. Saurabh Sharma. He's a nephrologist at Safdarjung, New Delhi.
Yes. Sir, diabetes is the leading cause of CKD in our country. So earlier there were only ACE inhibitor or ARB that can change the natural history of diabetic kidney disease. But in this era, we have SGLT2 inhibitor and dependent on this GLP-1 analog. So yes, definitely earlier, the early stage we can pick up the proteinuria and early CKD, we can manage it very better. We can manage better, and we can change the natural history of diabetic kidney disease with this SGLT2 inhibitor and GLP-1 and other non-steroidal mineralocorticoid.
This is optimism, and very well placed optimism. We can change the history, and we can change the future of metabolic disease. Dr. Ashu, your comments. Should we be happy? Should we be optimistic, the way Dr. Akash and Dr. Jamin has said? Or is there just sorrow and dejection all around? Our patients don't listen to us. Nobody bothers about what we say. People like alternative care and they just don't listen to us. What's your take on the future of metabolic medicine and the future of India's health? I think elections are coming up in a couple of states now. That's why Dr. Ashu has maintained diplomatic silence regarding that. But it's actually cause for optimism. We have so many drugs available now. Like Dr. Akash said, we have not only better drugs, we have better diagnostic and monitoring devices as well. Simple thing like heart failure, NT-proBNP, unstable angina, acute coronary syndrome, troponin T. It's so simple for us now, so easy for us. Technology is there, the drugs are there, the drugs are so economical. We thank our colleagues in the pharmaceutical industry. You cannot imagine how doctors in the US and Canada, even developed countries, have to struggle to get drugs for their patients. They have to navigate insurance, they have to navigate so many other regulatory hurdles. And for us, it is easy. When everything is available, all that is required is a little bit of effort from our side, a little bit more energy, more enthusiasm, and a little bit more of engagement with the patient. If we are able to explain to the community at large why we are using these pillars, if we are able to work as a team, then certainly we will win the metabolic Mahabharat. With this, I'd like to thank Dr. Akash. Thank you, sir, for being with us. Dr. Jamin, it's been a great pleasure, and we learned about both the left kidney and the right kidney from you. Thank you. And also Dr. Goyal. So it's been great, and shout out and thanks to everyone who is logged in with us on this 5th episode of Season 3.0 4D. Detailed discussion and diabetes dialogues, yes, in India, will continue. Any comments, Dr. Akash, before we conclude?
Thank you so much. It was learning from you, sir. You have given us a different perspective to the diabetes, the spectrum of the anti-diabetes drugs and all these things, sir. Thank you so much, sir.
Thank you, and thanks, Dr. Jamin. Together, we shall certainly win this metabolic Mahabharat. With this, thank you everyone for being with us. Don't forget to tune into the next show next week. Jai Hind.
That's it.
Dr. Ashu, you are there at exactly the right time. So, Dr. Ashu, our question was, yes, perfect. The metabolic Mahabharat. We have these pillars available with us that we spoke about. Do you think we'll win the war, we'll win the battle, or do you think that we'll never be able to defeat metabolic disease in India?
No, sir, we will be able to defeat the metabolic along with these 5 pillars which we have discussed, with the Metformin, with the GLP-1, with the SGLT2, with the non-steroidal mineralocorticoid receptor antagonist. So we can win the substitution with these pillars.
And on this optimistic note, let's move towards action. So from tomorrow, yes, thank you, sir. So from tomorrow onwards in our OPDs, we'll be re-energized and we'll make sure that we win this battle and the war against disease. Thank you and Jai Hind.
Thank you very much, sir. Thank you.